Welcome back. I'm Dr. Gupta again from Loma Linda University Medical Center, and I wanted us to get back on track and start talking about facial rejuvenation again. This is part 2, where we're going to go into attack mode against those wrinkles and against the aging changes that we all have in our face. So as we finish part 1, I summarized for you what some of the options are, and they of course start with relatively simple things such as skincare and light chemical peels. We moved on to talking very briefly about Botox and non-ablative resurfacing, and then we talked about more aggressive things, real resurfacing, as well as fat and filler injections. So that's really going to be the focus of this next session as we talk about these minimally invasive therapeutics for facial rejuvenation and what these things really mean, how we do them, and who's a good candidate for them. Again, I encourage you to look at your facial worksheet and think about the notes that you may have made as you watched part 1 on facial analysis. So what I really want you to understand at the end of this session is what's the right procedure for the right wrinkle. And we do that as a discussion with a patient when I'm trying to decide what the right procedure is based on a whole bunch of different things, the first of which is your downtime tolerance. How much time can you actually take off of whatever it is you do in the world, whether it's being a parent, whether it is with a job, or whether it is something that you're getting ready for, such as an important anniversary, a wedding, or a reunion. So that's what we call downtime tolerance. And downtime tolerance can be anywhere from 1 hour to 1 month. And that really helps choose which procedures we're going to do. So as I talk through the various options we have, I'd like you to keep in mind what your downtime tolerance is. Then we'll also talk about duration of effect. And really these first two things go hand in hand. The shorter your downtime tolerance, the less invasive I'm going to be, and quite honestly, the less duration of the effect you're going to have, or the less overall impact it's going to have. So there is a cost for improvement, and some of that cost is time, and time away from the things that you like to do in the world. There's also a classification called the Fitzpatrick classification, which is a measurement and a grading of how much pigment you have in your skin. And it's a grade from 1 through 6, where 1 is the lightest skinned person you know, and 6 is probably the darkest skinned person you know. I'm somewhere between a high 4 and a 5 on that Fitzpatrick scale as an example. Glow-Gal level is a photoaging scale that rates people in terms of how much wrinkling they actually have. And that correlates pretty well with aging, but it also correlates well with some very specific anatomic things that we'll talk about in a moment. And then finally, choosing the right procedure for the right wrinkle is all about what you, the patient, really wants. And if you don't care about a certain part of aging signs that you have in your face, then that's certainly not something that we should build into a treatment plan. So let's talk a little bit for a moment about the Fitzpatrick scale that I mentioned to you. Once again, it's grades 1 through 6, and this is commonly available anywhere online. It's a heavily referenced tool that we certainly use in choosing resurfacing techniques, and that's really where Fitzpatrick classification plays its biggest role. So when we talk about chemical peels and laser resurfacing, the Fitzpatrick class that you are is what really determines whether or not you're a candidate for that or not. The Glow-Gal classification, as I mentioned earlier, is photoaging. It's how much wrinkling has actually occurred in your face, secondary to both intrinsic and extrinsic aging factors. And it's a guide to how much resurfacing you might need to smooth over those wrinkling. As you get into the higher grades of grades 3 and 4, where there's really persistent wrinkling and not just wrinkles when you smile, and there may be some associated discoloration and so forth, though you'll see here that there's a category on the slide that mentions peels. I really think as you get into the higher levels of Glow-Gal, you're probably moving beyond the reach of minimally invasive therapeutics, and we need to think about more aggressive techniques such as high-end lasers and surgery. So let's talk about what the real options are based on your glow gal classification. So when we look at a young girl in her 20s, in her early 30s, where there are really no wrinkles, the only things that she should be focusing on are protective or preventative measures, sunblock at all times, considering some intermittent alpha hydroxy acid peels through a good esthetician, or even some of the ones that you can do at home are a good option as well. One of the things that we do take care of in these younger women are some cosmetic blemishes, which occasionally can be pigment related or maybe moles and so forth that we would operate on. When women start to hit their early 30s to their early 40s, they're typically in the glow gal 2 level, which means they have wrinkles in motion. When they animate their face, when they smile, when they raise their eyebrows, when they frown, we start to see lines in their face. And this is also the category at which sunblock is very effective. It's also the category at which retin A and its derivatives are very effective when used properly. Alpha hydroxy acid peels, glycolic acid peels are very good at this point. But then we also start to see a role for paralytics, which are the Botox family, as well as soft tissue fillers, which can be in the form of fat or some of the commercially available options such as Juvederm and Restylane. There's also some education that should go on to patients in this category in terms of the sun avoidance and, of course, modification of any of those extrinsic factors we talked about earlier. Glow gal 3 are the patients that do really start to benefit from both minimally invasive as well as slightly more aggressive therapeutics. These are people that actually do have some wrinkles even at rest. And sunblock is important for them, but these are patients that are going to start to need real resurfacing in the forms of medium depth chemical peels or laser resurfacing. And they're almost all going to benefit from fillers because they've reached this point because of some volume loss in their face. Botox can have a role to play in these patients as well. And some of the more mini lift type techniques in terms of facelifts and brow lifts and eyelid lifts also are pretty important and pretty practical for people at the grade 3 level of photoaging. And then finally, in the grade 4 scale, when we have patients who are really full of wrinkles everywhere on their face, they can benefit from some resurfacing in the form of peels and lasers, but they really are also going to need real lifts, brow lift, facelift in a deeper plane or with muscle component to the facelift, as well as combinations of all of these things are really what are going to make the most difference for patients in this category. So again, the right procedure for the right wrinkle means taking care of your skin. It means thinking about injectables, which can either be fillers or paralytics, and then resurfacing the skin, which can be in the form of chemical peels or laser and light sources. Here's a split face image of a woman who benefited from minimally invasive therapeutics only. And if you look carefully at the image, you'll notice that the right side of her face, of course, has been rejuvenated, and her brow is in a higher position, and there's less depth in the furrow between her eyebrows, and that's a Botox effect. It's also eliminated some of the hooding over the corner of her eyelid. If you'll notice, the lower eyelid has had improvement in the pigment there, and that happened secondary to some laser treatments that she underwent. And then the depth of her nasolabial fold has been corrected with the injection of a filler. Additionally, though it's not readily apparent, is the fact that her jowl is less obvious on the right, and that's also secondary to a filler injection, very strategically placed in front of her jowl. So let's talk a little bit about fillers that are on the market today. Of course, a variety of substances have been used as fillers for over 2,000 years. Unfortunately, most of the substances used 2,000 years ago are not particularly safe, and we certainly don't use them today. And that actually includes, believe it or not, things such as dirt, dust, rocks, glass, wood, cotton, and other naturally occurring substances, none of which, of course, make any sense today, since we know how the body reacts to those fillers. But there are, of course, the traditional collagen fillers that were highly reactive and really didn't have a long duration, that have been around for the last 30 years, but not very popular today. The most popular fillers today, of course, are hyaluronic acid-based fillers, and this, in today's marketplace, are the Juvederm and Restylane products that we see and are commonly used. These are very effective, very soft, very natural-feeling fillers that are very easy to administer. And anyone with a good knowledge of anatomy can predict where these fillers should go, and any skilled plastic surgeon or dermatologist can place them in those areas very effectively as well. The next level of filler that will last slightly longer is the hydroxyapatite-based filler. In today's market, that's Radiesse. And that's a product that'll probably get you nearly twice as long in terms of duration of effect as the hyaluronic acid fillers, but it's a lot firmer. And that means it's probably not a good choice in the lips, but it might be in some of the deeper furrows between the nose and the upper lip. And then the final category of fillers are really what we call volumizers, and in today's marketplace that's Sculptra. And these are products that do require multiple treatments, but do produce some degree of permanence in the correction of the folds and wrinkles that are used. All of those commercially available products leave one to be described, and that is, of course, fat. Fat grafting involves taking a portion of a person's own tissue and using that as a filler. Our experience with fat grafting and some of the research that we've done at Loma Linda has shown us that about 40 to 50% of fat that we remove from one part of the body actually contains living cells that can be successfully transplanted to another part of the body. And I wanted to take you through how we do fat injection. So here you see me with a patient on whom I've anesthetized the side of her hip. This, of course, is a procedure done under local anesthetic. And I'm using a syringe suction technique to remove a small amount of fat from her thigh. And here you see me pointing at the fat in a syringe. You'll also see there's a natural separation that's occurred between the fat cells and the red tinged fluid, which of course is blood tinged fluid around both a combination of ruptured red cells and the local anesthetic that I used. We then process that fat by spinning it in a centrifuge, and after removing it from the centrifuge, you see this 3-layer separation where there is the yellow layer on top, which is actually more of an oily layer from ruptured fat cells that aren't living. That nice white, orange tinged packet of fat cells, that's the portion that will live. And the red at the bottom is the blood tinged local anesthetic, which we're not going to use either. So we separate those 3 layers, keeping only the middle layer. We then put it into injection syringes, which are often much smaller than this, for placement then back into various parts of the body. And fat grafting is very effective for increasing the volume of a person's lips, as you see here in this example, but it's also very effective at correcting deformities secondary to such common things as skin cancer removals in portions of the face and post-liposuction deformities that we see. We're also using fat graft quite a bit now in the realm of breast reconstruction to help smooth over contours. Some of our research on fat grafting has revealed that there are adult-derived stem cells present in the fat, and these will actually continue to grow and transition the cells to the appropriate body type of cell that's needed where the fat graft is placed. And this is a technique that's really in active evolution, but that I believe is getting better and better and better as we move forward. There are, of course, people that overdo it. And when you overdo it, it takes a lot of work to reverse it. So I certainly don't recommend overdoing fillers in any form or at any time. So fillers then have a great role to play in patients who are probably anywhere from their early to mid 30s all the way up to their mid 50s who want to have correction of folds that are of the static variety, and that means that you have lines that are present not just when you flex the muscles of frowning or smiling or raising your eyebrows and closing your eyes, but actually have lines that are present at all times. Fat grafting is a favorite of mine, but I think that depending on your downtime tolerance and the duration of effect that you're after, the hyaluronic acids are also very good fillers, and it's a very good technique. What about Botox? Is Botox really a cure-all? There's a lot of press about Botox. Ever since it was approved by the FDA for cosmetic indications in 2002, people have asked a lot of questions about Botox, relating from is it safe to what can it do? Well, it is safe, and we'll talk a little bit about that in a minute. And as far as what can it do, well, it can help you in a lot of areas of the face. So Botox is a purified protein toxin that comes from the Clostridium botulinum toxin. And though it's been approved by the FDA since 1989 for a variety of spastic conditions, it's only been approved by the FDA for cosmetic purposes since 2002. It was used off-label for these purposes for probably an additional 10 years before that. So there really is quite a bit of long-term experience with this product now. In terms of a treatment overview, Botox is given with a very small needle. It hurts like a very small needle might hurt when it pinches through your skin, so it's very, very temporary pain. The effect takes about 3 days to reach its peak effect. One of the newer botulinum toxins on the market, which is Dysport, probably kicks in a little bit faster at around 36 hours. It lasts around 90 days, and that's about what I think people should count on from Botox. It'll have its peak effect somewhere around 10 to 12 days post-injection, and then it really won't start to decay until about 75 or 80 days. But by the 90-day mark, you will have some loss of its impact, and that impact is probably going to be nearly completely gone in a new Botox user by around 110 or 115 days. The areas where Botox is approved for injection is in the periorbital or around the eye region. So the forehead lines, the brow furrows, and the crow's feet are very effective areas that are very responsive to Botox. In terms of performing the treatment, we cleanse the treatment site. We mark the treatment site by having the patient execute the frowns or the smiles that bring the lines into place. And then we use a tiny needle. We use, for those of you that are familiar with the gauge of needles, we use a 30 gauge needle, which is a very, very small needle, to do the actual injection of Botox. One of the muscles that responds very well to Botox is the frontalis muscle. The glabella, which is the region between your two eyebrows at the root of your nose, is another area that's very responsive to Botox. Here you see an example of the central brow being injected in this patient. The crow's feet, which are formed by the muscles that circle the eye, are also one of the really responsive areas to Botox. It's probably one of my favorite areas to treat because you almost always get not just an okay result, but you really get a spectacular result in the crow's feet. Everybody notices when your crow's feet smooth out. Here you see the crow's feet being injected in this patient. The nasalis is or what many people call the whisker muscle around the nose, is not commonly treated. It's actually one of the signs in patients that have had a lot of Botox treatment. When they've had their brow and the forehead and their crow's feet injected, the nasalis sometimes becomes prominent. So it's a muscle worth considering in terms of having a Botox treatment there. Here you see the nasalis being injected at the sidewall of the nose. The muscles around the mouth and the main muscle, which is the orbicularis oris, can form what some people call smoker's lines. This is a tough area to treat with almost any method that we use. There's almost no surgical operation to improve this. So we rely on fillers and paralytics to do it. My experience with using Botox in this area is positive, but not nearly as positive as is with fillers. So only in a patient who's not willing to have slightly larger lips do I resort to Botox in this part of the face for correction of the lines. And here you see injection of the smoker's lines in the same patient. The platysma neck bands are also one of the really good areas to treat with Botox. It's very effective, it's very safe when done properly, and really can reduce the lines in a woman's neck very effectively. Here you see the neck bands being injected in this patient. Let's take a look at a few cases. These are people who had their forehead area rejuvenated with Botox. In both cases, the after images are taken 60 days post treatment, and you see, depending on how deep the wrinkles are when you start, you can either completely eliminate or definitely soften those lines considerably. Here are the crow's feet. Once again, one of my favorite areas to treat. It always works, and we get great results in the crow's feet with Botox. There are side effects of Botox. I'm happy to say that this is not a case of my own, but there are people that will develop a droop of their eyelid. I think it all has to do with your surgeon knowing exactly what the anatomy of the area is and which portion of which muscles are responsible for depressing your brow, bringing it down, versus elevating your brow, and making sure that we only block the brow depressors when we inject around the eyes. Side effects of Botox are a lot related to just treatment. They can be asymmetry, a lack of facial expression. You can get a little bit of bruising once in a while with Botox, but with that small gauge needle, the bruises won't usually last more than 2 or 3 days, and that's not a very common phenomenon. There's about 1 in 30 patients that will develop a headache after Botox treatment, and that headache can last as much as 24 hours. I don't think it's very common, but some patients have told me that areas that we've injected with Botox can go numb for a few hours. I don't believe that to be a common side effect. And then, of course, there can be an inadequate effect. If people have received too much Botox or Botox too frequently in the past, you can actually develop antibodies to the botulinum toxin, in which case the Botox is simply not going to work. And when that happens, we have to look at other options for rejuvenation. There is a very few and a very small number of patients, typically rated by the manufacturers of Botox as 1 in 100, who develop a flu-like symptom after Botox injection. I believe that's dose-related, and I think that careful dosing will completely avoid that side effect. So once again, in consideration of picking the right procedure for the right wrinkle, a lot of it depends on where you have aged and where you have wrinkles, as well as what your age is, and using good skincare based on alpha hydroxy acid peels that can be either over the counter or at an esthetician, combined with retin-A level or retin-A-based skin treatments and sunblock, are really that first arm of treatment. And then injectables with fillers and paralytics, which is the fat grafting, the hyaluronic acids, the Sculptras, versus Botox and Dysport on the paralytic side, are the next level. Finally, we come to resurfacing, which can be based either in the form of chemical peels or laser and light-based treatments. So I had the opportunity to visit a very renowned Japanese spa in Tokyo a couple years ago, where I witnessed the gold peel being performed. Gold is known for its medicinal properties and is felt to be a very anti-inflammatory product. So patients in Japan are often undergoing gold peels, and these are of course not liquid or molten gold, but chemical peels that have had some addition of gold to them. This is not something that we offer commonly in the US, I'm afraid. There are, though, a variety of resurfacing techniques that we do use. There's over-the-counter methods, and those are the alpha hydroxy acids and the salicylic acids that you can buy typically in the acne control section of your pharmacy. There's prescription level skincare, and these are things that under a physician's direction, an esthetician will probably guide you through, and these are almost always vitamin A based treatment, retin A based treatments, and are pretty effective. Then we move on to light peels, which are things, once again, that a skilled esthetician, in particular a medical esthetician, can help you with. Medium peels, which are typically done by physicians. And then non-ablative lasers and lights, such as Fraxel and fractional resurfacing, along with intense pulse light, photopeel level resurfacing, all the way up to ablative lasers, such as erbium and carbon dioxide based resurfacing, which are very aggressive treatments. The things that resurfacing can help with are really plentiful. We can help with photo damage, meaning all of the changes to the surface of the skin that have occurred secondary to sun exposure. Uneven pigmentation that can either have been splotchy or additional dark spots of pigmentation that can occur, or even light spots of pigmentation that sometimes occur in response to inflammation of the skin. Atrophic wrinkles are those lines that have formed because of a little bit of volume loss underneath or thinning of the collagen in the skin. Some early skin redundancy, meaning some looseness of the skin, particularly in the cheeks and around the chin area, can be tightened with chemical peels and lasers as well. And then precancerous lesions can be peeled and burnt off with lasers. Scars can be improved, and acne scars can be improved as well with resurfacing methods. So in choosing the resurfacing method, it's very important to know the patient's pigmentary type, whether or not they have any scars existing, and whether they've had any recent sun exposure, because recent sun exposure does inflame the skin and put you at risk for some specific complications of resurfacing, which primarily are related to pigment. The area of the face being treated also is very important. As we've talked about earlier, the lower eyelid skin and also the neck skin are very thin, and we have to be very cautious in those areas and adjust it. And depending on the climate that you live in, rosacea may be part of what is present in your skin. That's a redness that people will see of their cheek and the blood vessels around their nose, and that can limit what some of the resurfacing methods we should use are. The face does have different zones, as we talked about earlier. The forehead, of course, is very resilient, very thick skin. We can almost resurface the forehead with any of the techniques in almost anyone. But the eyelids, the area between the eyelids and the neck are areas we have to be very careful of. Peels have been around for an awful long time. Over 2,000 years ago, sour milk, which really in today's talk would be a lactic acid peel, was used very commonly. The Turks used a very controlled exposure to fire over 1,800 years ago to execute what we might consider today to be an intense pulse light rejuvenation of the skin. And that flaking and peeling that occurs after a sunburn is what was the goal of these old style thermal peels. Picking the right patient for a peel is also hard to do. The fairer the skin color of a patient, the easier it is to peel their skin and get predictable results. The darker and thicker the skin type is, the more risk there is of changing their existing pigmentation. Once again, that Fitzpatrick scale really weighs in heavily here, and while almost all laser and chemical peel techniques are safe on Fitzpatrick types 1, 2, and 3, there's only a few options for those of us in the higher categories of 4, 5, and 6. And once again, the Glow-Gal classification plays a role here too, where if we're headed towards resurfacing, we need to go medium or deep when we're talking to patients who have grade 3 to grade 4 with persistent wrinkles present. As we talked about earlier, there are actually some other benefits of resurfacing in terms of treating some pre-skin cancer lesions, and patients do need to be prepared for resurfacing methods by combination of prophylaxis against previous herpes and infections, as well as turning over the skin very rapidly with a retin A based treatment ahead of time. And sun exposure has simply got to stop before any form of resurfacing, and 2 months is probably the rule of thumb to go by. Superficial chemical peels just work on that most outer layer of skin. The medium peels will actually work on the outer layer, but also cause a little bit of damage to the dermal layer. And that's what causes collagen to build itself back. And we see remodeling occurring in these patients for many months afterwards. And then deep peels go completely through the epidermis and into the middle layer of the dermis, which is where some of the pigment containing cells are, and this is why we can sometimes see changes in pigment with the deep peels. So superficial peels are those that are done by estheticians, and the healing time is really as little as a day, maybe up to 3 or 4 days. And these are effective in smoothing over the skin improving minor surface changes, and giving a fresher face to people. And people will often do these in the days leading up to some big event, such as a wedding or an anniversary. These are often done with 10 to 15 to 20% trichloroacetic or TCA peels, or Jesner's peel, or even glycolic acid peels. And these are really quite safe and produce predictable results in most patients. Medium peels are more aggressive, more effective, and as a consequence do carry with them a little bit more risk as well. But these are good for mild wrinkles throughout the face, all the way from the hairline down to the chest, and can help improve pigmentary changes that have occurred secondary to sun as well. Here you see a patient undergoing TCA peel, which is a medium depth peel of the lower eyelid. And you can see that the skin has turned white, and that's what we call a frost. And we look for a very even frost in any place that we treat. And that's a sign that both the patient probably did a good job in getting herself ready for the peel, but also that we were able to apply the acid very evenly to the skin. Here you see a patient undergoing a TCA peel of the entire face at this point. The recovery from that level of peel is more like a week, and there is an active peeling process that occurs where skin flakes off over the course of that week, and there's some redness or pinkness to the skin at that point too. The skin will continue to improve for probably 6 months to a year, and we don't want to re-peel skin any more frequently than about 3 months if we're doing medium depth peels. Deep chemical peels in today's practice are done with phenol. This is not a technique that we use in our practice. Patients that would benefit from deep chemical peels in our practice are typically treated either with lasers or surgical facelifting. The risk profile of deep chemical peels and the recovery requirements from deep chemical peels in our experience are relatively excessive compared to the benefits, and that's why we have adopted the techniques of laser more commonly than these deep chemical peels. There is almost an expected amount of hyperpigmentation after deep chemical peels. It does go away after about 4 to 5 weeks, but this is not an uncommon finding in patients who undergo deep chemical peels. So to summarize, we start with skincare when we want to talk about minimally invasive options. We move on to injectables, which can either be used to restore volume in the form of fillers and fat grafting. We can paralyze the muscles that are causing dynamic wrinkles with Botox or Dysport, and then we can resurface the fine lines and pigmentary changes that occur in the face with either chemical peels or lasers and lights, with the bottom line being picking the right procedure for the right wrinkle. Doing so really requires the right surgeon, and I'm going to encourage all of you to only see members of the American Society of Plastic Surgeons who carry that symbol of excellence. Once again, your facial roadmap and your facial worksheet can be found online at plsurgeon.com under the Patient Resources section of the Resources tab, and it's the facial worksheet PDF file that's present there. I encourage you all to download that form, work through this webinar, and come up with your own roadmap for facial rejuvenation. Thank you very much, and I look forward to having you tune in when we talk more in the future about surgical options for facial rejuvenation.